Thanks, Sue, for that introduction. And thank you to all of you again for taking the time to be with us tonight. Welcome again. So I'm going to be sharing with you tonight about a topic that I think is important all year round, but has special relevance this month since it is Breast Cancer Awareness Month. And we're going to be talking about genetic testing for hereditary breast cancer risk. And I've titled this talk BRCA and Beyond because many of you may have heard of the BRCA or the BRCA genes, but hopefully you'll walk away from tonight having learned a little bit more about sort of what's more current in my area. So just to give a little outline for tonight, we'll start off with some basics about genetics and cancer, kind of take you back to high school biology for a little bit. And that'll help to set the stage for the rest of what I'll share with you, sort of what I look for in somebody's personal or family history for concerning signs of hereditary breast cancer, how we actually do genetic testing for cancer risk, sort of what the genetic counseling and testing process involves. We'll spend some time talking about what we do for people and families who have tested positive for a hereditary susceptibility to cancer. And then we'll kind of finish up talking specifically about our program here at Baystate, where patients can come for genetic counseling and testing. And as Sue said, there will be some time at the end for questions, and I will do my best to answer them. So to start off, again, just some basic biology. When we think about all the tissues and organs in our body, the building blocks of all those tissues are cells. And within each cell of our body, we have 46 chromosomes. They come in pairs of 2, so 23 pairs, one in each pair coming from the egg, the other from the sperm. And chromosomes are really storage units for DNA, which is a 4-letter code that is used to spell out genes. And genes are basically instructions that tell the body how to make what we call proteins. And proteins are responsible for carrying out pretty much all of the body's functions. An analogy that I like to use with my patients to kind of drive this concept home is to think about, if you hear the term genome, being the library of all the instructions the body needs to do everything it does. And actually, every cell in the body, brain cell, skin cell, heart cell, has that same library contained within each cell. And then again, think about chromosomes being kind of like a bookshelf where some of these instruction manuals in genes would be contained. And just because 2 genes are next to each other on the bookshelf doesn't actually mean they have anything to do with each other. In fact, a lot of the times they don't. And then why our different cells in our bodies can do such different jobs is because each individual cell or cell type is going to pull different instruction manuals or genes from those chromosome bookshelves. So not every cell is using every gene in the body. In fact, we have about 23,000 genes. Not every cell is going to use all of those. And then when we think about what genetic testing is, or at least the type of testing I do, is if we're thinking about a gene being an instruction manual, then the testing is essentially a spell and grammar check on these instructions, going letter by letter, looking for spelling mistakes or grammar errors. And we call those spelling and grammar errors mutations. They can also be called pathogenic variants, but for tonight, I'm just going to keep it simple and call them mutations. But again, all means spelling mistake, harmful change in a gene. So why we go looking for mutations is if a gene is written properly, spelled correctly, it's going to tell the body how to make a normal, functioning, healthy protein to carry out that task. If we see a mutation in a gene, that's either going to lead to a protein that's not working as well as it should, maybe to lead to not enough protein being produced, or even sometimes if it's a really bad mutation, we might not see any protein produced at all. So that's really kind of the significance of why we look at the genetic code, is to look at what's going to happen to that functional protein. And with the genes that I test for cancer risk, mutations, spelling mistakes in these genes are inherited mostly in what we call a dominant manner. Again, we have 2 of every chromosome. One comes from the egg, one comes from the sperm, and thus we have 2 copies of every gene, one from the egg, one from the sperm, one from mother, one from father. And then when we go to have a child, when somebody conceives a child, only 1 copy of the gene gets passed on. So with dominant inheritance, if you have 1 copy of the gene that's working and 1 copy of the gene that has the mutation, each child has a 50-50 chance of either inheriting the working copy of the gene or the copy with the mutation. And it's a coin flip every time. This picture is a little bit misleading. It's not like if you have 4 kids, 2 are definitely going to get it, 2 won't. 3 could get the mutation, 1 could get the mutation, none could. It's a random 50-50 coin flip every time. But something that I really do like about this picture is that it kind of illustrates the idea that a mutation could be inherited, where it calls this out on the side. A mutation could be inherited from either a mother or a father, from the egg or the sperm. And I think this is a really common misconception that like the father's, genetics or the father's family history doesn't matter, when in reality, it really does. These gene mutations can come from, again, egg or sperm, mom or dad. So now just switching gears a little bit, just a little bit of background about what is cancer. Again, think about cells being the building blocks that make up all of our different tissues. Sometimes, and this is usually a really gradual process over the course of a lifetime, certain cells in the body can start to accumulate abnormal characteristics and start to look a little bit different than a typical cell under a microscope. If enough of those abnormal characteristics accumulate, then you might see that cells start to divide, multiply, grow much faster, much more out of control than it should. And then if that kind of clump of cells, what becomes a tumor, it may start to even take on characteristics that allow it to invade into other tissues or harness the body's blood supply. So cancer really is a normal cell that's kind of gone haywire and starts to show this uncontrolled cell growth. So when I speak about sort of these abnormal characteristics, what this really is mutations, damage happening in certain cells of the body over time that's leading to mutations that accumulate and lead to cancer. So the left half of the screen is showing what happens with most types of cancer, sporadic cancer, where you start off with a normal cell. And again, this is only certain parts of the body, only certain cells. And gradually over time, they acquire mutations and can eventually become cancer. What's different about hereditary cancer is that somebody is born with that harmful gene mutation. And we just talked about a minute ago, it's actually there from conception. As this picture is kind of showing, that's not enough to cause cancer. So being born with one of these cancer risk mutations, most of the time, is not going to automatically lead to cancer. It's not like these people are born with cancer already occurring. Something else has to happen over time, more cell damage, more mutations in order for cancer to happen. So it's almost like, before I go on, almost like that person is born one step into the cancer development process, but again, doesn't actually have cancer. And when we think about the genes that this damage or mutation is happening in, they kind of fall in 2 different categories. This damage isn't happening in any of those 23,000 genes we have. It's only in certain ones. And I kind of think another analogy for cancer is think about almost like a car driving down a highway, out of control, driving as fast as it can. It might have gotten that way because maybe something has happened to the brakes. We have certain genes in our bodies called tumor suppressors that tell cells how to keep from growing out of control, to die off when they should, how to not proceed with growth if they're not supposed to. So again, think of those like brakes. And then we have other genes which are called proto-oncogenes, which are, when they're working properly, again, written properly, spelled correctly, are involved in normal cell growth and survival. Some cells are supposed to divide and grow. So when we see mutations that can lead to cancer, either those are like the brakes getting cut, mutations in tumor suppressor genes, or in oncogenes, where it's almost like a mutation is leading to someone stepping on the accelerator to kick that cell growth into overdrive. In the case of the genes that I test for, these are almost exclusively tumor suppressor genes. So we all have these genes. We want to have them because when they're written properly and spelled correctly, again, they're telling the body how to keep cells from becoming cancerous, keep them from growing out of control. And again, this is why if somebody has the genetic testing that I do and they test positive for a mutation in one of these cell break tumor suppressor genes, It does not mean that they're going to get cancer or that they have cancer in that moment. It means they have higher than average chances for cancer because they were kind of born with one set of brakes cut. But if you think about a car, there's not just one set of brakes. Usually there's a couple, and then like an emergency brake. So again, that in and of itself does not mean cancer is going to happen. Other damage has to happen in certain cells of the body, other mutations over time in order to see cancer happening. There is other sort of genetic testing that people often think about when it comes to cancer that genetic counselors like me don't typically order. Oftentimes when somebody gets a new cancer diagnosis these days, their actual cancer cells, the tumor cells, get genetic testing, looking to see what has accumulated there over time. We call these somatic mutations. These are, again, what's happening only in certain cells of the body over time, not what somebody's born with. And this type of genetic testing is used to guide treatment, to try to find targets for treatment for that person's cancer. Once in a while, it can pick up a mutation that actually was there from birth, but again, that's not what the testing is designed to do. And I wanted to mention this tonight because we do get patients coming in sometimes and they say, oh, my mom had testing on her tumor and they found a mutation, I'm worried about it. Most of the time, though, mutations that get picked up in tumors are not ones that family members would be at risk for. So again, just to sum up the last couple slides, all cancer is genetic, the result of mutations, but not all of it is hereditary. Most of those mutations have not been there since conception from the beginning. And in fact, most breast cancer is not hereditary. I think this picture shows nicely that most breast cancer happens by chance. Happens because of a multitude of factors that I'll touch on in just a minute, but only about 5 to 10% of cancer, breast cancer at least, is hereditary due to, in large part, one of these inherited gene mutations. And then there's this other subset of breast cancer where maybe there's a strong family history or some concerning signs in the person's own history of breast cancer, but the genetic testing comes back negative. We don't find an underlying hereditary risk or contribution. I think in time, over time, some of these families will probably move into the hereditary category as the testing gets better. We learn about new cancer risk genes from time to time. The testing technology improves, but based on our current understanding, this is kind of the breakdown. So most people who do this testing come back negative because most cancer, again, is not hereditary. So when we think about factors that can contribute to cancer, and most of those sporadically occurring cancer, it can be a multitude of things. And oftentimes it's really difficult to answer that question of why exactly somebody's cancer has happened, unless we do find one of these hereditary contributions. Most of the time, it's a tangled web of environmental exposures to things like harmful chemicals, radiation. Lifestyle factors can play a role too, things like smoking, heavy drinking, diet, exercise. Age is a big risk factor. Most cancer happens to people later on in life. Sex at birth can be a risk factor. Males and females can get breast cancer, but it's much more likely to happen in a female. And then things like hormone exposures can play a role too. For instance, how many years has a woman had a period? Did she ever take birth control pills? Things like that can add to cancer risk as well. So when I am looking at somebody's personal and or family history of cancer, there's certain kind of red flags I look for that might point me in the direction of thinking maybe this family does have a hereditary predisposition to cancer being passed from generation to generation. I look for cancer at much earlier than average ages. I look for rare types of cancer. And then I look for multiple cancers, and that may be somebody who's had more than one cancer. And I'm not talking about cancer that spreads in one place, starts in one place and spreads. That's metastasis. That's actually considered all one cancer. I'm talking about it starting in more than one place. I'm also looking for multiple generations impacted with cancer, and whether that doesn't necessarily have to be the same type of cancer, it might be sort of a collection of cancers that tend to go together. So when we think about breast cancer, this is not a rare type of cancer. It's pretty common. Unfortunately, 1 in 8 women gets breast cancer at some point in her lifetime. About 12% of women will. So then there's other signs that I look for beyond just presence of breast cancer that, again, might make me concerned that the cancers in a family could be hereditary. Specifically, I'm looking for breast cancers diagnosed at or before 50, triple negative breast cancer, and that's when the tumor cells are lacking the receptors of estrogen, progesterone, and HER2/neu. I'm looking for people who have breast cancer and have Ashkenazi or Eastern European Jewish ancestry. They are much more likely to test BRCA positive than the average person. I'm looking for somebody who's maybe had more than one breast cancer, like if they have breast cancer in both breasts, that tends to be two separate cancers. I'm looking for males who've had breast cancer. And if somebody's own personal history doesn't sort of fit any of these red flags, then I go looking kind of more broadly at the family. And I look for somebody who's had breast cancer and has a close relative with male breast cancer, ovarian cancer, pancreatic cancer, prostate cancer that either is behaving very aggressively. That might be somebody who has what we call like a high Gleason score for prostate cancer, or prostate cancer that has spread and metastasized. And then kind of beyond, if none of that is in the family history, we operate under the rule of three. So if we see three people in a family who've had breast and or prostate cancer, then these are all, again, concerning signs that a cancer could be hereditary. So if you're starting to think, well, maybe some of these signs are in my family, what kind of questions should I start to ask of my relatives who've maybe had cancer, or the people who know the family history? We want to know, how old was somebody when they were diagnosed with cancer? And an approximation is fine. Like if you can guess the general decade, or if somebody knows about, again, within 5-10 years, that can be really helpful. The age that person passed away can be helpful too, and to know if they passed from their cancer, although the age of death is actually not as critical for a genetic risk assessment. We want to know what type of cancer was the relative initially diagnosed with, because again, if cancer starts in, say, the breasts and ends up in the lungs, it's not lung cancer, it's breast cancer that's spread. So we don't want that being misconstrued as lung cancer when say it's really breast. Has anybody in the family had genetic testing? We want to especially know if somebody who's had cancer has had testing. And if so, can you get a copy of their test report? These test reports are most informative if they're from the person who's had cancer. So even if it's a negative result from somebody who's had cancer, that can tell us a lot. A negative test report from a relative who's never had cancer, that doesn't help us as much. And I'll get to that a little bit later, why that is. Pathology reports from a relative's cancer diagnosis can be helpful. They can be tough to get sometimes. So we don't sort of try to get, it's not as important for us to get those. It's more the genetic test reports that we're really looking for if we can get them. And oftentimes, if you're being referred for genetic counseling, certainly here at Baystate and many other cancer genetics clinics, you're going to be asked to provide this information either via a family history form or in the form of a family tree. And in that, they're also going to ask about both people with and without cancer. It's helpful to know about people without cancer as well, because say you have a really big family and you've got a bunch of relatives who haven't had cancer, then that's probably less concerning for an underlying hereditary susceptibility. Plus, it's helpful to know when somebody's coming in for a genetic counseling visit, do they have kids? Do they have siblings, nieces, nephews who might be impacted by test results for them if they choose to test? So it can be helpful to have that info going into a visit. And I'm sorry, can anybody hear? I'm in the office and somebody's cleaning outdoors outside, so I'm just going to put in headphones real quick.
Yeah, I can't hear anything.
Oh,
but yeah.
Okay. Well, if that becomes a problem, Sue, please let me know because I can hear.
Yeah, I think you're good.
Okay, thanks. Okay, so when we get somebody's family history and we're sort of assessing it, we're always looking for who's going to be the most informative person for the whole family to have testing. Genetics isn't just a business of the individual, it's a business of the family. And so we're usually trying to see if we can have somebody who's had that young, that rare multiple cancers test first, because they're the person in the family who we're going to expect to test positive. And if that person with that concerning cancer history does test positive, and we know what that mutation in the family contributing to cancer in the family is, then we can offer their relatives really targeted testing instead of trying to cast a wide net. So that can be helpful. And then on the flip side of that, if that person with the concerning cancer history tests negative, then that's probably pretty reassuring for the whole family. Because if that person tests negative, the chances of, say, their unaffected siblings or children testing positive is just so low. We know that's not always possible, though. Sometimes the person who's had that really concerning history has passed away or says, I'm really not interested in this. And that's okay. If that happens, then we try to test the people who are kind of most closely related to them next, because again, that's not only giving us information for that person, but sort of everybody who comes after them, their children, their grandchildren, etc. So say, you've been referred to us, we look at your family history, we say, yeah, we think you should come in to talk about testing. What can you expect in a visit with a genetic counselor? Usually we're going to start off the visit just making sure you know why you're there. Sometimes people just say, oh, my doctor sent me here. I don't really know what this is about. So we're going to talk about, okay, sometimes people can be born with increased risk for cancer. We'll talk about, we'll go over usually some personal medical history to kind of assess their risk factors in your own medical history. We'll go through the family history together to make sure we're offering you the most appropriate test. And again, so we have a sense of who in the family might be impacted by test results if you choose to test. We'll go through possible test results and sort of what the implication of those could be for you and your family. And at the end of the visit, we kind of check in and we see, is this something you're interested in? Genetic counseling does not have to equal genetic testing. We're never in the business of pushing people into testing. It can be a really personal choice whether or not to find out this information. So we never want somebody to kind of, go into it without having thought about it. That's part of our job, is to make sure people feel like they know what they're getting into when it comes to this testing. But it's not right for everybody. So, that's another common misconception. You don't have to have testing if you come to meet with us. Something that we are probably going to offer to you, though, if you do come into us to talk about testing, is what we call panel testing. Many years ago, when it came to hereditary breast cancer, all we had to test for was BRCA 1 and 2. And those two genes are still sort of our usual suspect genes when it comes to hereditary breast cancer. If somebody does test positive for breast cancer predisposition, most of the time it's in those two genes. But these days, we know there are several other genes that are linked with increased chance for breast cancer. It's not just the BRCA genes. So usually if somebody has a concerning personal or family history of breast cancer, and we don't know about a mutation in the family already, usually we're going to try to check all of those genes, because any one of those could be at play, and we just don't know until we test. And then the flip side of this is, unfortunately, when it comes to almost every breast cancer risk gene, it's not just a breast cancer risk gene. It can also increase the risk of other types of cancer. So the right side of the screen is showing, for example, there's a gene called TP53, which can really increase the risk of breast cancer, especially in very young women, but can also increase the risk, honestly, of almost any other type of cancer. It's really a very significant cell break gene. And if it's got a mutation in it, a lot can go wrong. So panel testing is this concept of we're testing multiple genes all at the same time, kind of casting a wide net, trying to leave no stone unturned. And this is an example of a panel test that I talk to patients about often. It's from a lab called Ambry Genetics. The names of the genes included on the test are listed in the left-hand column. And then across the top, those are the different types of cancers, tumors that somebody might have higher chances for if they tested positive for a mutation in a particular gene. So you can see it very much depends on what gene we're talking about, what the cancer risks are. The check marks in each row show what those types of cancer that person would be at risk for are. And this particular test is actually a breast and gynecologic cancer risk test. That's why you'll see there's a handful of genes on here that don't have the breast column checked off. But this really shows pretty much all of the genes we know about right now that are linked with increased risk of breast cancer. So you can see it's not just BRCA1 and 2. So in terms of the testing itself, a lot of people want to know, well, how was this done? It's a blood test. It's a normal arm blood draw. You don't have to fast or do any special preparation. We can do the testing on saliva, but it's not as ideal. What can happen with saliva is sometimes they don't get enough DNA out of the sample to even run the test in the first place, and then it fails, and then we have to try blood the second time anyway. There's also a certain way of spell checking the genes that we can't do on saliva. So we try to get blood if we can, but we understand that's not always possible. From the time somebody gets their blood drawn, on average, it's about 3 weeks to get results back. We can ask for them more quickly, and they will come back more in the range of like a week and a half, if somebody needs those results to say plan for a surgery if they've been recently diagnosed with breast cancer. Usually what's going to happen is their genetic counselor will get the test report first. Check out their results. If they need to do any further investigation about the results, they may take some time to do that. And then at least here at Baystate, we start with a phone call with the results. We review what the results mean for the patient and their family, and then we kind of go from there. Other genetics clinics may have you come in for the results. And certainly for our patients, if they want to come in to talk about their results more, that can happen. People often also want to know about cost of testing. And most health insurers do approve this type of testing for patients who meet sort of criteria, who have, young breast cancer, multiple people with breast cancer in their family, breast and ovarian cancer. Usually they approve the testing. Even so, even if there are issues with health insurance, the testing labs that we send the testing to, and we don't do this testing here at Baystate, it goes out to kind of independent genetics labs. They all cap the out-of-pocket cost for patients at $250. So usually we try insurance first. If that ends up costing patients any more than $250, the $250 is the cash price. So you can always switch over to that if insurance is going to cost you more. Most patients, though, never have to deal with that, though, because most patients whose personal or family history meets criteria end up paying less than $100 for the testing. Okay, so in the event that somebody comes in, has their testing, and we find a mutation for a breast susceptibility gene, what happens next? Usually the first thing we're going to do, if we don't already know about a mutation in the family, is talk about, okay, what is this gene all about? What do we know about cancer risk linked with this gene? And I wanted to use BRCA1 and 2 as an example for tonight, because again, these are sort of our usual suspect genes, the ones that people test positive for most often. And this table is showing you, again, these aren't just breast cancer risk genes. They also substantially increase the risk of ovarian cancer, prostate cancer, and to a lesser degree, pancreatic, male breast cancers, and melanoma a little bit with BRCA2, not so much with BRCA1. So with these two genes, it is a substantial jump in risk. Again, 1 in 8, about 12% of the average woman population will get breast cancer at some point in her lifetime. For a BRCA1 or 2 positive woman, that is up to 80% risk. For ovarian cancer, the risk is much higher, with BRCA1 than it is with BRCA2. Although when we compare that to the average woman's chance for ovarian cancer, which is pretty small, it's a really substantial jump in risk. Prostate cancer, it's sort of, with BRCA2, it's more of a substantial jump in risk. And then with these other types of cancer, again, it's a higher than average risk, but once we start talking about pancreatic cancer, male breast cancer, most people who test BRCA positive are never going to get those types of cancer, but they have above average risk. And, I think this also shows, again, this is not just something that can impact females, it can impact males, especially with BRCA2. Men have a substantial increased risk for prostate cancer. And both males and females have pancreases. So that is something to consider as well. And then something too, before I move on, I don't want to forget to mention that, especially with the BRCA1 and 2 genes, not only is a woman at an increased risk for getting breast cancer once, she's also at increased risk of getting a second breast cancer. And again, not really the first one come back, but a whole new one. So that risk is something to contend with too when she's making decisions after testing positive. So once we kind of talk about, okay, what sort of risks are you up against? Then we're going to talk about, okay, what can we do about those risks? And this testing is really all about prevention. We're not just testing people so we can say, hi, it's a really good chance you're going to get cancer. Good luck. It's now what can we do to either start watching you really closely so that if cancer does happen, hopefully we're going to catch it really early on when it's quite treatable. Or are there steps we can take to reduce those increased risks for cancer? And I wanted to show that this little picture at the bottom, not only because last week was actually National Hereditary Cancer Week to sort of raise awareness for these families who are facing these increased risks for cancer, but to just get you familiar with the term previvor. There was a day last week dedicated to previvors, which is this group of people who have a positive test result but have not actually developed cancer. And now they're facing their risk of what am I going to do next? So for almost any breast cancer susceptibility gene where somebody has an above average risk for breast cancer, we're going to at minimum offer them extra screening. And there's a few different ways we can do this. Again, kind of monitoring for early warning signs of breast cancer. From 40 onward, we're going to recommend for most women an annual mammogram. But if you have above average risk for breast cancer, usually we're also going to recommend an MRI of the breasts in addition to a mammogram. And the picture on the left is just a little picture of sort of a general idea of how a breast MRI is done. MRI is the machine where you go in a tube, and it's usually pretty narrow. They slide you in, and MRI uses magnets to take the pictures. So with a breast MRI, you kind of lie down Superman style, and then the breasts are in an indentation, and that kind of allows the machine to take the best pictures possible of the breast tissue. If somebody's at that increased risk, we not only want to offer them another way of looking at the breast tissue. MRI takes pictures in a different way than a mammogram does, but we want to try to alternate those images every 6 months. So mammogram, MRI, with the idea being we're screening pretty frequently. So again, hopefully if breast cancer does happen, we catch it early on. If somebody is facing a really high risk for breast cancer, say they've tested BRCA1 or 2 positive, or for that TP53 gene I mentioned a minute ago, we might start those MRIs as early as the 20s. There are some other breast cancer risk genes that don't come with as high of a risk, where you might say you can wait until your 30s, 40s to start the MRIs. And then with mammogram, we don't usually start that as early as the MRIs, but the very earliest we do that, say for the BRCA genes, would be around 30. And beyond imaging, breast exams are important too, where a health provider feels for lumps. If you're gene positive for breast cancer risk, ideally, we hope you end up seeing a dedicated breast specialist who can feel for lumps, but also having that exam from a primary care provider or OBGYN is important too. So ideally, somebody would be getting that clinical exam, somebody feeling for lumps at least twice a year. And then self-exam can be helpful too, just kind of general awareness of what's trying to understand what feels normal versus abnormal for your own breasts. But it can be really hard to know what you're feeling. So really the imaging and the clinical exams are the most important things. But if you're gene positive, you'll also get some training on how to do a self-exam. So again, those are sort of the ways we try to watch more frequently and then usually earlier on in life for those early warning signs of breast cancer. When it comes to ways that we can try to reduce risk for breast cancer, we usually talk about surgery in the form of a preventative double mastectomy, or, the technical term, medical term here would be prophylactic bilateral mastectomy. This is a big surgery. It is not like you're in and out of a morning kind of thing. And the recovery reconstruction, that can be a long journey. It can get complicated for some people. So it's not one we sort of offer willy-nilly. And it's really sort of when that chance of developing breast cancer at some point in the lifetime tips over 50%, like it does with the BRCA genes, that we start to discuss mastectomy as an option. And the idea here is, surgical removal of both breasts to try to get as much tissue off as possible to bring that risk for breast cancer as close to zero as we can get it. We can't get it entirely to zero, though, because unfortunately can't guarantee that every single breast cell gets removed, but it sure gets it as close to zero as we can. It's not for everybody. We certainly never push mastectomy on gene-positive people, but again, it becomes an option. Some people really feel like if I didn't do something preventative, I would be so anxious waiting for cancer to happen every time I go in for that MRI or mammogram. Or some people just say, that sounds like a real big hassle, going every 6 months for imaging. And sometimes the imaging requires you to get a follow-up biopsy or another image. And some people say, I don't want to deal with that. I'd really rather do something preventative. But again, there's options. Unfortunately, when it comes to many breast cancer risk genes, mutations in these genes also increase the risk for ovarian cancer. And I'll get into this more in a minute, but with ovarian cancer, we usually go a preventative route because there's not such good screening. So oftentimes, if you test positive again for breast cancer risk gene, we're also talking about eventually taking out the ovaries and the tubes. And again, the medical term here is prophylactic bilateral salpingo-oophorectomy to reduce that risk for ovarian cancer. But if we do that prior to menopause, that can actually reduce the risk of breast cancer as well. Because when we take the ovaries out, that's essentially sending somebody right into menopause after surgery. The other thing we can talk about when it comes to prevention in terms of a medical intervention is there are certain medications that can reduce the risk of breast cancer. So this idea is called chemoprevention. The two that we think about most with reducing breast cancer risk are tamoxifen and raloxifene. We're mostly talking about using these in women who, again, have not had mastectomy and have reached menopause. The research on these genes and on these medications and breast cancer risk reduction has mainly been done with the BRCA 1 and 2 genes. We don't have as much data for gene positive people for the other breast cancer risk genes. There's been data that's shown that for somebody who's already had breast cancer, taking tamoxifen raloxifene can cut their risk for another breast cancer happening in half. And this may even be the case for somebody who hasn't had breast cancer, but is BRCA 1 or 2 positive. It may reduce their risk of getting breast cancer to begin with. Again, when we were talking about panel tests, we talked about breast cancer risk genes are not just breast cancer risk genes. They're increasing the risk for other types of cancer. Again, ovarian cancer is one we often think about. And the reason we're talking mostly about surgical prevention for this type of cancer is because we don't have something like a mammogram or a blood test that gives us reliable early warning signs for ovarian cancer. There's things we can do, it's just they're not that good. So usually we're talking about the ovaries and the tubes. We know actually a lot of ovarian cancer starts in the tubes. But timing is really important with this surgery because, again, ovaries come out and menopause happens right away. So we don't want to take them out too early because that can actually hurt somebody's heart or bone health. And also, if somebody wants biological children, they need to leave the ovaries in. So we want to respect those wishes as well. For something like, say, increased risk of colon cancer, we have really good screening and prevention for this in the form of colonoscopies. Nobody's favorite procedure, but not only do they look for early warning signs of colon cancer, if there's a precancerous polyp in there, they take it out so that it doesn't have the chance to become cancerous. And again, with genetic risk for colon cancer, usually we're talking about doing this procedure more frequently than average and starting earlier on in life. Most people these days start at 45. If everything looks good, they go every 10 years. Again, that wouldn't be the case if you were gene positive for colon cancer risk. And then in terms of chemoprevention for colon cancer, for some genes, we do talk about aspirin on reducing the risk. I wanted to dedicate a slide just to pancreatic cancer screening because some people may not be aware that this even exists. It's still fairly new, but we've been doing it here at Baystate for a few years now. We have 2 gastroenterologists who are specially trained to do this type of screening. It either involves endoscopic ultrasound, which is what is shown in the picture on the left. Basically, a ultrasound probe is attached to a scope that is snaked down through the digestive tract to try to get as close to the pancreas as possible to take pictures. We can also use specialized MRIs to take pictures of the pancreas. Since it is so invasive and you really need to have somebody who's specially trained to read these images, right now, it's not being offered to just anybody. It's really being reserved for the very highest risk people. And that would be somebody who's not only gene positive for pancreatic cancer risk, but also has a family history of pancreatic cancer. We're also offering this to people who maybe have that strong family history of pancreatic cancer, but have a negative test result. And then finally, there's 2 genes that I've mentioned here, CDKN2A and STK11, where that risk associated with mutations in those genes, the pancreatic risk is so high that we say that's enough to justify thinking about doing this screening. Prevention can actually go along, lifestyle prevention can actually go a long way when it comes to pancreatic cancer and reducing risk. And the big thing here is not smoking. If you have an increased risk of pancreatic cancer, smoking can really do a lot of damage to the pancreas, and we want to try to preserve, kind of protect the pancreas as much as possible. And then, I've been talking mostly about sort of things we might do for somebody who's not in active cancer treatment or maybe has not had cancer. But for people who've been recently diagnosed with cancer and get a positive genetic test result, there can actually be targeted treatment that takes advantage of their gene mutation to better treat their cancer. And what we think about mostly with breast cancer is something called PARP inhibitors. These drugs were actually developed for people who have inherited BRCA1 or mutations, and they kind of take those cells growing out of control and they kind of take them down a pathway where they die off like they should be. And it's a pill, it's a daily pill. And we're finding that this is having really applications for so many different types of cancer. There's constantly new sort of cancer types that these drugs can be used for. Right now, it's breast, ovarian, prostate, and pancreatic cancer, but it may be that there's applications for other types of cancer. And again, now they're not just being used for people who have one of these inherited gene mutations. There's other situations where these can be used. And then, the other big thing why, some people are pursuing this testing to guide their own cancer risk and be better informed about their own cancer risk and their own care. But again, genetics, we're dealing in the business of families. So what does this mean for somebody who's tested positive? What does this mean for their families? Anybody who's a first-degree relative, so a full sibling, a child, a parent of somebody who's tested positive has a 50-50 chance of testing positive themselves. So we always are, going to recommend trying as best as somebody can to share the positive result with their family so that they can think about their own testing. If the family member is positive, then they can get that kind of proactive care we've been talking about. And if they're negative, they might not need any additional screening or prevention beyond what we recommend for the average person. That's not always the case, but sometimes that can really sort of get them off the hook, so to speak. Ideally, we want to try to test, again, the people most closely related to the positive person first. This is what we call kind of cascade testing. The idea here would be almost like, say somebody tests positive and they have 2 sisters, and each of their 2 sisters has 4 children. Rather than trying to test all those 8 nieces and nephews, if we can test the 2 sisters and say they test negative, then their kids probably wouldn't need to be tested. So again, it's sort of what's most informative for the family. Generally speaking, with these genes, and there are some exceptions, but most of them do not increase the risk of cancer in childhood. So usually we say people can wait till they're 18 to test, not only because we're not going to do anything differently for them in childhood, but waiting till they're an adult lets them make that decision of if they want that information for themselves. And then again, just to drive home this point once again, men can test positive for these genes, and they can and they should consider testing, not only for, if not for themselves, but for the benefit of, say, their children, grandchildren, etc. And I think this was really highlighted well in an article that was in Newsweek a couple of weeks ago. This was a woman who's a physician now in California, no family history of breast or ovarian cancer. Her father was recently diagnosed with pancreatic cancer. He tested positive for BRCA2 mutation. And unfortunately, this woman, Shoshana, also tested positive for the same mutation. So again, there was nothing related to female cancer in the family, but her dad got testing. And I believe the article talks about he got on a PARP inhibitor and is doing pretty well. The other kind of way that, this information can be helpful for family members is for young people who have not had kids or are sort of in the middle of their reproductive period when they're having children. Some people who are gene positive say, I'm not going to have biological children. I don't want to risk passing this on. And then I've had patients who have been the flip side where, they were sort of saying, I was waiting to have kids to know if I was at risk. I tested negative, I'm going to go forth and try to conceive. There is also technology these days that can be used to test embryos, do genetic testing on embryos. This is called pre-implantation genetic testing. You have to go through the IVF process first to create an embryo in a lab, but then they let those embryos grow up a little bit. They take out just a couple cells, do genetic testing on those cells, and then only use embryos that don't carry a mutation to create a pregnancy to effectively prevent a mutation from being passed on. Not everybody's on board with this. It can be kind of expensive, but it is out there and available to people who are positive. And then kind of the flip side of all this, what if the testing is negative? Great news for somebody in their family, they can't pass on something they don't have themselves, but may not answer that question of why has the cancer happened in the family, and certainly doesn't erase the family history. So that person may still be considered high risk if they have a strong family history of breast cancer. They may need an MRI in addition to a mammogram just based on family history alone. And that's something that a genetic counselor or a high-risk team could help to assess. If the person who's had testing is not somebody who's had cancer, chances are other people in their family should still think about testing. A negative result for somebody doesn't really tell us much about, say, their siblings or their cousins. So oftentimes we're saying, again, good news for you and everybody who comes after you, kids, grandkids, may not tell us much about anybody else. If testing is negative, and again, we don't know about a gene mutation in a family already, usually we're going to say, check in with us every few years because this testing gets bigger and better over time. And maybe you carry a mutation in a gene that we don't know about yet, or a mutation that we just can't detect with the current technology. And then certainly we want patients who are negative to stay in touch if the family history changes, as we may want to offer broader testing in the future. Again, I mentioned earlier, there's some reasons why people choose not to test. And the big one is really the anxiety surrounding a positive result, sort of the feeling that if I am at increased risk of cancer, I would just always be waiting for the other shoe to drop, really anxious about cancer happening. And while we can act on the cancer risk, we can't change the spelling of our genes. Another thing that comes up is, and I'm not going to get into this too much tonight, but the results don't always come back clear-cut positive or negative. They can come back ambiguous. And for some people, that uncertainty in their results can be really hard to move forward with and sit with. Having information for families, the family members, is often a motivator for people to pursue the testing, but it can also work the opposite way, where some people feel like, maybe especially for people who've already had children, I couldn't bear the thought of knowing that I may have passed this on to my child. And certainly nobody would choose to pass this on. And until recently, we haven't had any control over that. And some people just feel like, I wouldn't even know where to begin to start to tell my family about a positive result. And, genetic counselors are here to help with that, but we typically can't be the one to actually share the news with the family. It's kind of, up to the patient with our help sort of in the background. And then just very practically, there are some insurance implications with positive test results. If somebody's tested positive, it can then be very difficult for them to get long-term care or disability insurance. So sometimes people choose to go out and get those types of policies before they do testing. Fortunately for health insurance, there is a federal law that protects this. So if somebody tests positive, they cannot then lose their health insurance or have their costs go up. And employment is protected by this law as well. You can't be fired, not hired, or mistreated at work based on a positive result. And then, some people have already been through this genetic counseling and testing process before, and they might say, well, do I need to come back and see you? Certainly, if you had testing before 2013, we would say yes, because chances are all you were tested for then was just BRCA 1 and 2. If you were tested pre-2013, there was a certain way of spell checking the genes, not just BRCA 1 and 2, but all genes that became available to everybody at that point, but wasn't done routinely on everybody before then. And then more recently, there's a new technology called RNA analysis that is picking up a small percent of mutations that would be missed otherwise. But really, this is having more utility in sort of clarifying some uncertain results that can come up. Again, if the family history has changed, we want to know about that. Share that with your genetic counselor, your high-risk specialist. That might justify more testing. And then if you've had 23andMe or similar kind of recreational testing, this is not medical grade testing. It's not comprehensive. It should not be relied upon. And then finally, just to share a little bit about our program here at Baystate, the Family Cancer Risk Program is what I work out of. It's a collaboration between genetics, oncology, and the breast center. This picture's a little bit old, but shows most of the people on our team right now. We meet once a week to review new referrals and help to determine who's best to see them to start. Should they come right for genetic counseling and offer testing? Are they better to see the high-risk screening program at the breast center? Should they go straight to oncology? And then we often bring patients back who've already maybe had some breast imaging, who've had genetic testing, to make sure if they need to be followed up with one of the other departments that happens. And then finally, we really try to make sure that if somebody is tested positive, that their family members who are local and are interested in testing can quickly and easily get in to see us. So if at this point you are interested in coming to visit with us, we do not take self-referrals, so you can ask your primary care provider or OBGYN. Those are the two that usually refer to us. There's our phone number there. We have a dedicated patient navigator, Elizabeth. She's lovely. She reaches out to patients to start to collect their family history. That can be done via a paper form that she sends you, or she would invite you to our online tool. And then if we review that information and we say, yeah, the next people you should see are the genetic counselors, my department, genetics, would then call to reach out to schedule with either myself or my colleague Ariel, who's our other cancer genetic counselor. We see patients at 2 locations. Our main location is actually the Children's Specialty Center. That's where I am right now. Genetics falls under pediatrics at Baystate. That's why we're here. And then we recently opened up a clinic site at 3400 Main Street. It's right next to the Tumor Center, but it's actually a more office style setting that some people are more comfortable in. And then just to finish up, here are some resources if you're interested in learning more. Kind of the main support organization, information organization for hereditary cancer is called Facing Our Risk of Cancer Empowered. There's another group called Sharsharet, which is mainly for people of Jewish descent. And then the National Society of Genetic Counselors is sort of my field's governing organization. And there's a really nice tool. It's a website called findageneticcounselor.com, where if you're thinking, hey, I have a relative who lives in Texas who should really think about this, they can plug in their zip code, check off that they want to see a cancer genetic counselor, and it'll sort of spit out everybody in their area. So that's it from me for tonight. At this point, if there's questions, I'd be happy to answer them.
Thank you, Alexandra. That was a great presentation. I love the explanations and the graphics, the images that you had with it. I thought it was really well done, so I applaud you. We do have a number of questions, a few questions. Oh, and a few more coming in. The first one is, you mentioned tumor testing. Is that the Oncotype DX test or something else?
Yes. So Oncotype DX is a type of tumor testing. And again, that's a type of test that's going to try to help to guide the oncologist about what's the next best step for treatment.
Thank you. Next question. Is anastrozole as effective as tamoxifen for chemo prevention?
That is a great question. Going to be better for a breast oncologist. So I'm not the best person to answer that. Although I do know they prescribe that, but I'm not as well versed on sort of who that's most appropriate for.
Very good. The next question: what genes are tested if there is a family history of colon cancer?
Good question. So kind of the ones I think about most often, there's 5 genes that can cause something called Lynch syndrome, which is the most common hereditary form of colon cancer. It can also increase the risk of endometrial cancer or uterine cancer, ovarian cancer, stomach cancer, and actually a few others. So we definitely want to make sure those get tested. And then there's a handful of other genes that can lead to somebody usually first having a lot of precancerous colon polyps. The big ones would be APC. There's another one called MUT-YH. And then there's a handful of others. Usually we test for about 20 in total when it comes to hereditary colon cancer, but those are sort of the main ones that people test positive for most often.
Thank you. Next question. Are there side effects to PARP?
Again, I'm probably not the best person to answer that question, but I do know sometimes there can be problems with, say, like bone marrow with PARP inhibitors. But again, I don't want to speak too much to that just because, again, that's medical oncology is really the experts in that area.
Maybe this next question you won't be able to answer either, but does PARP work for all cancers or just BRCA mutation or breast cancer?
It definitely hasn't been FDA approved for all cancers yet, but breast, and again, not all situations, but certain types of and certain presentations of breast, ovarian, prostate, and pancreatic. Again, initially designed and kind of tailored to people who have those inherited BRCA mutations. But if you have a BRCA mutation that's occurred over time, just in the cancer cells, sometimes then that's appropriate. And there's a few other situations as well.
Thank you. That question was asked by Amanda. So if you had some follow-up, just let me know if you need more information on that. Next question. Can you take PARP at any age if you have the mutation? Example, if you have taken a prophylactic measures for some of the cancers associated, however, there are others that there is nothing prophylactic to be done. Is this a potential prophylactic treatment for things like pancreatic cancer?
It's definitely not being used prophylactically right now. Maybe in the future that could be an application. So right now it's used as treatment. It's usually not the first line of treatment for most of these scenarios where it's appropriate. Usually it's like, okay, you tried another chemotherapy first, and then PARP is used. So I hope that answered the question.
There's a comment here. Thank you. This has been very informative. I have to agree.
Oh, good. I'm glad.
really very informative. And we're just about at time too. So This has worked out pretty well.
Yeah.
We do have another minute. I just want to say thank you very much to everyone that attended. And thank you to you, Alexandra, for the great talk.
Sure, it's my pleasure. And if anybody sort of is in the process of being referred or will in the future, I also go by Allie. Most people call me Allie. So if you hear anybody talking about Allie and genetics here at Baystate, it's probably me.
There's one last, if you want to take this one.
Sure.
I've just been diagnosed with DCIS breast cancer. My family members have had different cancers, i.e. brain, lung, and kidney. Would I ever be able to get genetic testing?
Well, first, I'm sorry to hear that you've been recently diagnosed. That's something a lot of people with a new diagnosis want to know, is this appropriate for me? It's a little bit hard for me to say that without knowing more about kind of your own, characteristics of your cancer, like your age. Lung cancer doesn't tend to be hereditary, so that's not one we usually get too concerned about. but sort of with the others, it would depend on like how old were your relatives when they were diagnosed. So if you're concerned, I definitely talk to your oncologist. And, it doesn't hurt to get referred, give us a little more detail about the family history, and then we can, again, kind of assess a little bit better.
Excellent. Thank you.
Sure.
One more.
Okay.
I guess, if you're okay.
Yeah, that's fine.
Okay. Do you have to be diagnosed with one of those cancers before taking PARP?
Currently, yes.
Okay. Very good. Well, we are at time. So thank you again, Allie, for your great talk. And thank you for everyone for joining us.
Yeah, it was my pleasure to be here. Thank you for having me. And thank you to everyone again for taking the time to be with us tonight.